with this center for past 9 years. I worked there. I've done my PhD there. So, and I've just come to this place to have some more experience in the field, and yeah. So today we will be discussing about the risk of bias assessment in the included studies. So before I go further, so am I audible to everyone?
Yes, sir. You please continue.
Okay. So okay, as you are doing this course, so you must be aware of the term evidence-based medicine. Can anybody define for me what evidence-based medicine is? You can type in the chat box if you want. Okay. So it is basically a triad of patient concerns, clinical expertise, and best research evidence. So today we are going to discuss about the best research evidence. What do you mean by best research evidence? Okay, this is a hierarchy graph, and it shows that randomized studies are at the highest level, followed by cohort case, control case series. And then hierarchy of evidence, it also says that systematic reviews and critically appraised articles are even better than randomized controlled trials. But why do we say this? Why systematic reviews are better and why not randomized controlled trials? So it is because of the fact that while we do systematic reviews, we take into account the various lacunae that could have been there in a randomized controlled trial. So one of those faults or lacunae is bias. So what is bias? So okay, and anything that is a deviation from the truth is called bias. Uh, or there is some systematic error. So if like in a class, if a teacher favors a particular student, she is always biased towards giving him more marks. So it is a similar kind of a thing in the trials also. If an investigator is biased towards an intervention, he'll try to design a trial in a way that he gets the result what he wants. So this is what we need to look for if there was any chance of bias. So what it can do, if there are bias in the studies, they could lead to misleading reviews, and then you'll be always doubting the results of that trial. Okay. So in a city, this is basically a flow diagram of a randomized control trial. So I've been told that you will be going through the classes of the design, conduct and design of randomized control trial as well as diagnostic control trial. So this is just an overview. So we have some participants, then we allocate them to treatments, and we assess the outcomes, and then the study is published. So at every step there could be a bias. While selecting the participants and allocating them, we could have a selection bias. While assessing the treatments, there could be performance bias, and there could be a detection bias at the outcome assessment level, and then attrition bias also, and then there could be reporting bias. So these are very fancy names, but they are very easy to Uh, uh, they are very basic things, but the names are very fancy, like attrition bias, detention bias, detection bias, something like that. But they are very simple concepts. So okay, so this is one of the cartoons that I always keep in my presentation. So okay, in a jungle, so this man wants to select some animals for the exam, and he says that every animal has to go through a common exam, and that is they have to climb the tree. So what do you think is he doing? This a fair selection method, or the result will the result be representative of all the animals in the jungle? What do you think? So this is a simple question. You can just type yes or no. Okay. So I don't think so that this is a good way of selecting the representative animals from a jungle, because at the end he will only have monkeys. Okay, so here you can see this is the general population, and there is an intervention that is for this target top population. So which sample population will be the best representation? Will be the best for conducting a trial. So the one that is fully inside the target population, or the one that is not inside the target population. Okay. So for me, the one the circle that is inside the target population will be the best one. So, but how do I select them? Why only? So there are methods to select a sample population from a target population. So we do randomization when we are talking about a randomized control trial. So we do random sequence generation, and it helps to avoid selection bias. It determines the random order of assigning people into intervention and control groups, and it gives equal opportunity to every person of that group to be a part of the trial, and anybody could go to could be, has equal opportunities to be selected for the intervention as well as the control group. So so it minimizes the chance of bias for cherry picking the participants in a trial. So when do you call it a low risk or a well performed randomization? So when you have used some random number tables or compute or it is a computer generated random number, or you have done a stratified or block randomization. So, and when you call it a high risk, when it is a quasi randomization, for example, you have enrolled participants on the day of their visit or the day of their birth, or you have just on the choice of the clinician, you have just enrolled them. So this so why do you say that on day of a visit could be a high risk randomization? Because you nobody knows who is going to come on the day of the visit. So supposingly, if I am planning a trial, I say all the participants coming on Monday will be given the standard treatment, and all the participants coming on Tuesday will be given the new intervention. Hello. So am I audible?
Yes, sir.
Okay. So I'm not getting any answers. Okay. Anyhow, so the next concept is the allocation concealment. So once we have randomized the participants, the other thing is the to conceal their allocations. So it is usually done at the start of the trial, and it is also done to avoid selection bias. So once you have recruited participants, when you have recruited the participants, it should be unpredictable for him to know that which group he's been allotted to. So it helps to prevent changing the order, and it also prevents selecting who to recruit. So how do you ensure allocation concealment? It is again by the computer generated randomization, and then there are sometimes we use envelopes, but if they are not opaque, you can make out which group the participant is going to be, and then you can intervene and change the group, and it can introduce bias. So therefore, using opaque envelopes is a good method. Then comes the performance and detection bias. So it is basically related to the blinding or masking of the participants. So who is blinded? Only participants, only investigators, or both, or outcome assessors, or analysts, or either all of the four. It basically helps you to prevent for the performance bias. If the participant is knowing what treatment he's going to get, or the investigator is aware of the treatment the participant is getting, so then he can be biased towards that, and there could be some performance bias introduced. And if the outcome assessor knows which group the results that he is going to analyze belongs to the new intervention, or the standard treatment, then he can introduce the detection bias. He could be biased towards toward detecting the failures. He could be so so these are the two other bias. So here you can see the investigator is blinded.
Performance detection bias, can you explain once again, please?
So performance bias is basically when the participants and investigators are not blinded, so they can it can affect the performance of the treatment, because if the participant is aware that he's getting a new drug, so he might be reluctant to take it, or he might not take it, and uh, and he might just fill up his performer, and he might tell the investigator that okay, I've done it, but he has not taken the drug. Sometimes some investigators are biased towards the new drugs. So if they know that a particular participant has been given the intervention, so they will be more inclined to provide better care to the participant, that can result in some different outcomes. So that will affect the performance of the trial. And if the outcome assessor is aware of the treatment groups, then he might be very critical of analyzing the results for a particular group, and he might end up detecting more adverse events or more failures for that group. So that will introduce the detection bias. So this is basically a very very basic concept about these two.
Oh, thank you. Thank you.
So here in this cartoon, you can see that the investigator is blinded, the participant is blinded, and the treatment is also there's no label on it. So nobody knows which treatment they are getting. And some trials use the word blinding, some trials use the word masking. Both are same. Then the other bias that can be introduced is through the crossovers and dropouts. So if you have more dropouts or more withdrawals from a trial, and you don't uh, and you don't and you just ignore them, then your results will be different. Whereas when you try to analyze them, why the dropouts were and what were the reasons for the dropout, the results of you get will be totally different. So uh, that means that you need to be careful about your dropouts. You need to know everything about them, and if there are crossovers and they are analyzed in the group, uh, they are not randomized to, then the results will be different. So these two will bring again the they will create a missing data, and then there will be a will be bias. So to overcome these, we use the method called intention to treat analysis. So that means once you are randomized to a group, you will be analyzed in that group, no matter if you are drop out, if you have been drop out, or if you have crossed over to another group for a better treatment. So then this is so can anyone tell me what is this? So okay, so here you can see uh, person on the right is trying to kill the person on the left, and whereas on the screen you can see the person on the right is trying to kill the person on the left. So this is basically an example of a reporting bias. So you may get the results that are not desirable, but when you are trying to report them, you are reporting it in a form that is totally different from what the results were, and that brings in the reporting bias. So sometimes you have planned for four outcomes, and you are just uh, giving out only giving out one outcome showing that the intervention is useful, whereas the other three outcomes were telling you that the intervention was not useful. So then it brings uh, the bias that is called as reporting bias. So then these were the bias that were related to the randomized control trials, or the randomized design of studies. So then there are some non-randomized studies for intervention. Sometimes you have before and after studies, you have quasi-randomized studies, you have case control studies and cohort studies, from where you try to find out the results of the interventions. So when you are trying to plan an observational study, you should always ask the question that how would the study be conducted if it were possible to do it by controlled experimentation. So that means it should be conducted in one should be vigilant uh, about the study, so that it could be as comparable as a randomized control trial. So there could be biases due to confounding, there could be biases due to selection, there could be biases in the classification of the intervention. So at the pre-intervention level, at the intervention level, there is bias in classification of intervention, and at the post-intervention level, there could be bias due to deviation from intended interventions, due to missing data, due to measurement of outcomes, and in the selection of reported results. These are pretty much similar to those in the randomized control design. So, for example, the first three, bias due to confounding, bias in selection of participants into study, and bias in classification of intervention, they can introduce the selection bias. Then deviation from intended interventions, it can introduce the performance bias. Missing data is for the attrition bias, and measurement of outcome is again a detection bias. Then there is selective reporting or reporting bias. So this is a graph, a summary of risk of bias summary graph that is being generated using the RevMan, and this is a traffic light plot, and this can be generated using either RevMan, or it can also be generated in the Microsoft Excel. So these are the ways to represent various forms of various risk of bias in the studies that are included in a systematic review. So the other quality assessment or risk of bias assessment tools are Newcastle-Ottawa scale for the cohort and for the case control cohort and cross-sectional study designs. And then there is Robbins one, that is risk of bias assessment in non-randomized studies of intervention. So these are the various tools for assessing risk of bias in intervention studies. So now we come to the diagnostic accuracy studies. So then there are some biases that are different to a diagnostic study. So when you are doing a diagnostic study, you have in a randomized control trial, you assess for the internal validity and the external validity. So the internal validity is based on the bias and precision, that is the quality of design, and external validity is based on the clinical question and other variations. So there are two pathways for a diagnostic study where we can detect bias. One is the selection of the participants, and how the selection of the participant is going to affect the selection of the test. So you can select any population here, but how it is going to apply to the real world, that is again a question. So there are always two parts in it. So you have a target population and then you select a study sample and then you select study participants. So if there is any problem here, it will introduce a selection bias. But the studies that you had on which the study was conducted, how they apply to the target population is again a question. And if there is any flaw, it is going to affect the test. Then there's a bias called a spectrum bias in diagnostic studies. Okay, I've got a hand raise from Monica. Okay, so there's a spectrum bias. The key parameter in patient spectrum is the difference in the measured test parameter between the disease and the non-disease cases. Diagnostic accuracy is greater in a study of population with advanced disease than a population with less severe disease. So that means if you have a diagnostic test that is intended to detect a severe disease and you have selected a population with less severe disease, it is there's going to be you are going to introduce a spectrum bias in it. Similar and disease severity, it can be influenced by many factors such as setting, referral patterns, and prior testing. So all these factors could give rise to differences in test performance that reflect actual differences in disease severity. So it is important, therefore, to fully describe the severity of disease in the patient population along with other factors that could be associated with disease severity. And this difference in the disease severity is referred to as spectrum bias. So while you are doing a systematic review of diagnostic test studies, and while defining your PICO, you should clearly define the severity of the disease, and after that you should select your studies. If you're if you're doing a review for a diagnostic test in a severe disease condition and you have selected studies with less severe disease, it is going to introduce a spectrum bias. Uh, Then there's a classification bias. So that is error in the reference test causes classification bias. So these could be of two types: differential misclassification and non-differential misclassification. So in differential misclassification, the error is associated with index test result. And in non-differential misclassification, the error is independent of the index test result, but this can underestimate the sensitivity and specificity. So the magnitude of bias depends on the disease prevalence, the accuracy of the index test, and the degree of misclassification. Then there is diagnostic review bias and incorporation bias. That means these types of bias occur when the interpretation of the reference test is not independent of the index test. So that means diagnostic review bias occurs when the interpreter is aware of the results of reference test. So if it is just like the detection bias in a randomized control trial. So if the result is known, if the result of one test is known, then there are high chances that the interpreter is going to give similar results for the second test also. So therefore, the reporting the results should be blinded, or that the cases were reviewed again to obtain a blinded diagnosis. Then there is incorporation bias that occurs when the result of the index test are explicitly used as a criteria for the reference test. So that means the reference test is to be performed only when the index test is positive or if it is negative. So that means the results are going to affect the application of the reference test. Then it is an incorporation bias. Then we have this QUADAS two risk of bias assessment tool to assess the risk of bias in diagnostic test studies, and it is done it has four phases. First is state the review question, develop review specific guidance, review the published flow diagram for primary study or construct a flow diagram if none is reported, and then judgment of bias and applicability. And QUADAS 2 consists of four key domains, that is patient selection, index test, reference standard, and flow and timing. So that means the these four the questions are to be framed under these four categories. So in the phase one, that is the review question. So we break down the question in the PIRT form. Then we tailor our quadas to according to our review question. And when once there is good agreement, we apply it to all the included studies. And if there is no the agreement is poor, we again go to the tailoring step. Then we tailor the tool again, and we again produce guidelines how to use the tool, and then we pilot the tool and the guidelines. Then phase 3 is the flow diagram. So that is to review the published flow diagram for the primary study or to draw one if none is reported for that. So that means how to draw a flow diagram in the published study, that how the patients were recruited, what was the order of the test execution, and how the number of patients undergoing the index test and reference standard. Then a hand-on diagram is sufficient as this step does not need to be reported. So you just need to draw a flow chart based on your assessment of the study that should have these three components, and then you proceed to apply your quadas to assessment. So there are two domains of each question. So first part is regarding is regarding the bias, and it comprises of three sections. That is information used to support the risk of bias judgment. What were the signaling questions and what and their answers, and what is your judgment of bias? And then additional signaling questions are included to assess the judgment. If all the signaling questions are yes, then risk of bias is low. And if any signaling question is no, then there is a the answer to any signaling question is no. Then it raises a flag, and the authors need to look for any bias then. And we use unclear only when there is insufficient data to permit the judgment. Then the other part is the applicability part, and it also has some questions, and then we, based on the bias that we have seen, we rate the applicability for the test as low, high, or unclear. And this is how the results are presented. So you can see the risk of bias uh, for patient selection, index test, reference test, and flow and timing. So there are four domains, and for the applicability concerns, there are three domains. So this is the summary graph. That is all from my side.
Thank you, sir.